everyone, my name is Helga. I'm one of the clinical nurse specialists in infection prevention and control at Rockingham General Hospital. Thank you all for taking the time to join me today. Before I begin, I would like to acknowledge the traditional custodians of the land on which we meet and pay my respects to elders past and present. Today, I'll be presenting a critical discussion of the Infection Control Management Plan developed specifically for the medical ward at Rockingham General Hospital. This is a 20-bed acute medical ward with 8 single rooms and 12 shared beds, caring for a diverse and often complex patient population. The ward is supported by a multidisciplinary team of around 40 staff, including doctors, nurses, allied health, and patient support services and administrative staff, all led by a highly experienced nurse unit manager. It is a busy, high acuity environment where clinical needs shift rapidly and where infection prevention must be both proactive and deeply embedded in everyday practice. Like many acute medical wards, ours faces a number of significant infection risks aligned with National Safety and Quality Health Service Standard 3. We see frequent use of invasive devices such as IV lines and urinary catheters, which naturally increases the risk of device-associated infections. The ward also manages patients colonized or infected with multi-resistant organisms such as methicillin-resistant Staph aureus blood infections, VRE, Candida auris, CPO, and with rapid patient turnover, the opportunities for cross transmission increase. Shared equipment, high-touch surfaces, and the constant pressure on environmental cleaning all contribute to the risk profile. We also experience seasonal change in respiratory viruses and at times delays in recognizing infectious symptoms on admission. Operationally, we face challenges such as practice variation across disciplines, limited isolation capacity, and workload pressures that can compromise aseptic technique as well. Communication gaps between clinical and support teams can also impact timely escalation and infection risks. So these are not hypothetical risks, they are reflected in our recent data as well. So in the past 6 months, the ward has experienced several notable infection events. We had 3 peripheral intravenous cannula-related Staph aureus bloodstream infection, which triggered a review of device care practices. We also had 3 hospital-acquired Clostridium difficile infections, which were classified as an outbreak and required an organizational response. Another event was a suspected tuberculosis case was not isolated promptly, resulting in the delay in transfer to the negative pressure room and a large-scale contact tracing process. Our hand hygiene compliance currently sits at 81%, which is the borderline of the national benchmark, and this is a concern too. And we identified that several medical staff were not competent in aseptic technique, which is a critical gap in a ward with a high device use. These events highlight the need for a structured, proactive, and setting-specific infection control management plan, not just to respond to incidents, but to prevent them as well. The purpose of this ICMP is to provide a clear, practical, and ward-specific framework for infection prevention and control. It supports early identification and escalation of infection risks, reduces preventable hospital-acquired infections, and promotes consistent and evidence-based practice across the multidisciplinary team. It also strengthens the ward's culture of safety and accountability, ensuring alignment with the National Safety and Quality Standard 3, local epidemiology, and organizational priorities. In short, the ICMP shifts the ward from a reactive approach to a proactive and prevention-focused model. This ICMP is not a standalone document. It sits within a broader governance structure. At Rockingham General Hospital, infection prevention is supported by organization-wide policies, risk management frameworks, quality improvement system, and mandatory education requirements. These systems ensure that infection prevention is embedded in clinical governance and that staff capability is continually developed and maintained. The ICMP is overseen by the Infection Prevention Control Committee, which is IPCC, which reports to Rockingham General Hospital Clinical Governance Committee. This ensures the accountability and transparency and alignment with the Department of Health Western Australia policy frameworks and our local organizational policies as well. Our IPC team at RGH, Rockingham General Hospital, consists of 2 clinical nurses and 2 clinical nurse specialists, supported by an expert infection prevention and control consultant. Together, we provide surveillance, education, outbreak management, policy development, and frontline support to clinical areas. The rationale for this ICMP is grounded in the risks and the events I have already described. We have documented infection incidents, gaps in staff competency, and system-level vulnerabilities. The ICMP directly addresses these issues and aligns with the South Metropolitan Health Service strategic objectives, including patient safety, quality improvement, and antimicrobial stewardship. It also reflects the contemporary evidence, such as the work of Smith and colleagues, who highlight the effectiveness of ward-specific infection control bundles introducing device-associated infection. I have mentioned this reference at the end. The ICMP integrates seamlessly with, first of all, National Safety and Quality Standard 3 compliance, the risk management framework, antimicrobial stewardship programs, and continuous quality improvement cycles. This ensures that infection prevention is not an isolated activity. It is embedded in every aspect of clinical area. The IPC professional plays a central role in the success of the ICMP. Our responsibilities include surveillance, data analysis, policy review and development, education and training to the workforce and to the patient and carers, auditing and monitoring on different areas, outbreak management, staff health management, which includes hand skin integrity assessment, their pre-employment health screening, occupational exposure, incident management, and also consumer engagement, and finally the research as well, current researches. We also act as role models and escalation points for staff, supporting them to navigate complex infection risks and system barriers. The ICMP was developed through a multidisciplinary collaboration involving IPC professional, of course, then medical ward physicians, nursing leadership, currently the nursing stakeholders like nurse unit manager, staff development team, and the ward coordinators and the experienced nursing staff, then the allied health professionals, patient and carer representatives, and the clinical governance committee. The development process was grounded in surveillance data, which is hospital-acquired infection trends, a variety of audit results, staff and patient surveys, and patient feedback. This ensures that the ICMP is not only evidence-based, but also responsive to the real-world challenges faced by staff and patients. To ensure the ICMP is understood and used effectively, a multifaceted communication strategy is essential. This includes share the ICMP through intranet publication, targeted email distribution, discuss in board meetings, quick reference guides, posters, workflow stickers, screensavers, and small group education sessions. Operationalization is achieved by embedding the ICMP into existing workflows, such as closely monitor intravascular access device documentation, for example, peripheral intravenous cannulation chart and observation record monitoring, and also informing the real-time, creating the real-time and informing the coordinators about the micro alerts for multi-resistant organism, for example, for MRSA, VRE, Candida auris, CPO. Maintain the aseptic technique checklist and monitor all the clinicians who are conducting the intravascular device management, competency management. Ensure the isolation requirements, etc. at the bedside huddles, and also importantly monitor the environmental cleaning audits. The designated IPC professional supports staff, identifies barriers, and escalates issues as needed. Effective implementation requires adequate resources as well. So also we make sure the alcohol-based hand rub at the point of care and adequate personal protective equipment supplies, cleaning resources are readily available, and appropriate reprocessing of reusable equipment. Without these, even the best ICMP cannot be succeed. Evaluation is continuous and data-driven. It includes ongoing surveillance of hospital-acquired infection rates, monitoring of hand hygiene compliance. RGH is participating in National Hand Hygiene Initiative, and we are conducting 2 audits per year at the moment. However, if there are increased hospital-acquired infections, we conduct a local audit too. And device-associated infection indicators. For example, the key performance indicator, KPI for Staph aureus bloodstream infection is equal or less than 1 SAPC per 10,000 occupied bed days. And also the incident reporting, trend dashboards, and routine audits for aseptic technique, PPE use, cleaning, and isolation practices. So the real-time feedback is provided to staff, and the results are displayed on board dashboards to promote transparency and engagement. Stakeholder feedback is also essential through surveys, debriefs, and safety huddles. The ICMP undergoes formal annual review with accountability to the IPCC and the Clinical Governance Committee. The revisions are based on new evidence, audit findings, outbreak investigation, staff feedback, and organizational priorities. This ensures the ICMP remains current, effective, and responsive. The targeted benefits of this ICMP. Ultimately, the ICMP aims to deliver, first of all, reduced hospital-associated infection and improve patient safety, enhancing the patient compliance, increased staff satisfaction, and finally, cost savings for the organization. So these outcomes aligns with the national standards and contemporary IPC literature. So in conclusion, the ICMP for Rockingham General Hospital Medical Board is a comprehensive, evidence-based and governance-aligned framework that addresses the ward's specific infection risks and operational challenges. It strengthens clinical governance, supports staff capability, and promotes a culture of safety and accountability. Most importantly, it positions the ward to deliver safe, high-quality, infection-free care for every patient, every time. Thank you very much for listening. I welcome any questions or reflection. To close this presentation, I would like to briefly acknowledge the key sources that informed the development of this ICMP and the critical discussion today. Thanks again for listening. Please share your insight.